Sorry about the confusion, everybody. I apparently sent out the wrong link, and so we're going to use the protocol committee meeting invitation, which is what I sent out. So if you see protocol committee meeting up at the top, it is not the protocol committee meeting. That was yesterday. We'll get started here in just a minute. I want to give everybody a chance to kind of get logged in on their various devices. There are also going to be a repeat of this probably later today. Sharonville's out on an incident and going to be tied up for a little bit. So some of them may be watching this again later today. But we'll get started here in just a minute. Okay, can everybody see my screen? Awesome. Okay, give me just a minute to rearrange my pictures, etc., and we will go. No, we don't want to. Okay, there we go. All right, well, again, sorry for the confusion, but we'll go ahead and get started. Today, we're going to be talking about obstetrical emergencies for EMS. We're going to have some videos. They're all animated videos, okay? So there's real life videos that are available on YouTube, but I decided for the purposes of our education stuff to just use animated videos. But we're going to go through and discuss a whole bunch of different aspects of obstetrical emergencies. So we're going to talk about some of these common obstetrical emergencies and discuss kind of how a normal delivery goes and then how a not so normal delivery goes. We're also going to discuss some of the complications that can happen as a result of being pregnant, such as how do we handle cardiac arrest, trauma, hypertensive crisis, preeclampsia and eclampsia, et cetera. Hopefully by the end of this, you guys will have a little bit more confidence in at least the knowledge part. Sharonville does have an obstetrical simulator coming out, I believe either later this month or early next month. So there is no real hands-on component to this particular training. What I would recommend, though, is that all of you go find the obstetrics kit on your ambulance so that you know where it physically is located. And then, you don't have to open it, but it should have a list of the equipment that's in it visible through the plastic wrap. And so just familiarize yourselves with, what's contained on that. So there are a bunch of things that happen, during pregnancy. We start off literally as, one cell that then begins to quickly divide, et cetera. But we really don't get very big kind of until that late second trimester, third trimester. We divide things up into these trimesters simply because they have significantly different physiologic and anatomical changes. During that first trimester, you're essentially going from, those cells and folding the embryo and creating a brain and creating a heart and creating all of the various organs, et cetera. Once you get past that first trimester, a lot of that really big movement of things has ceased. And at that point, you are more growing the size of those organs, getting those organs actually doing things. And then, once you get into that mid-second trimester, that's when really the focus at that point of the fetus is just simply growth. The caloric expenditures go up significantly because baby is now, growing bone and muscle and brain tissue and other things and adding fat, et cetera. So those last, few months of pregnancy are essentially just incubating. You're just growing the kid so that they're able to support themselves outside the womb. We typically consider about week 23-ish to be the lower limit of viability. What we mean by viability is the ability for the fetus to support itself outside the womb. There are cases where there have been, kids successfully, survived at 20 weeks, but those are in the single digits. Um, the problem is that you still do have some tissue growth that is occurring. And typically the thing we worry the most about is lung growth. So if we have someone that we're concerned about preterm delivery with, we sometimes will start them on steroids, with the hope of getting that kid's lung tissue more mature than it should be for that given week. That way they're more able to support themselves. Even then, though, by survival, I mean, they likely have significant deficits. They may be ventilator dependent, those kinds of things. Once you get above kind of that, 26 to 28 week, mark, then the likelihood of survival drastically increases. Anything that is occurring from week 36 forward, we consider that to be a full-term delivery. And the reason for that is this is somewhat of a science on dating, date of conception, et cetera. But sometimes people's memory is wrong or the measurements aren't adding up. But once someone hits about week 36, if they start to go into labor, it's no longer considered a preterm labor. It's just considered, an early delivery. And those kids do just fine. So mom also is undergoing a lot of physiological changes during this time. The biggest ones tend to be the increased blood volume and their heart rate. As the mom, begins to grow the fetus, they of course have to, increase the production of red blood cells and, begin carrying additional water. All that water that they have to carry is in the form of plasma. And so they develop sort of like this physiologic anemia because their plasma volume increases more than their red blood cell production increases. Their cardiac output also has to increase about 30 to 50%. So it's a pretty significant amount. And the reason for that is we've got to perfuse this growing uterus, but we've also got to perfuse that placenta as it attaches to the uterus and begins to grow. And so there's a significant demand put on mom's heart. Unfortunately, a rare complication of pregnancy is hypertrophic cardiomyopathy, which is where the heart grows, big and becomes swollen and floppy as a result of it. And unfortunately, it has a 20 to 30% mortality rate. I've diagnosed it a few times, and it's always a tragic thing. Obviously, the uterus has to grow. Initially, it's really not doing a whole lot. The first couple weeks of baby's growth are just off of the uterine lining, and the placenta really hasn't gotten much of a blood flow established yet. So as this uterus is growing, of course, that requires a lot more energy from mom. The uterus, of course, is not going to be able to stay within the pelvis as baby grows. So as baby grows, that uterus basically lifts up and out of that pelvis, that pelvic ring, and up into the abdominal cavity. Any of the females who have given birth can probably attest to, having baby kick their bladder and kick their stomach and, kick their diaphragm and things like that. And so it gets rather crowded in there, as you can imagine. Additionally, especially as we begin to get later in the pregnancy, we get a lot of smooth muscle effects, on the body from hormones. Some of these hormones are put out by mom. Some of these hormones are actually put out by the placenta. Relaxin is one of the more common ones that we think of. And no, it's not the 5 o'clock somewhere kind. Get it? Because you're relaxing. I'm sorry, it's a bad joke. Um, Relaxin literally helps to loosen up everything. The pelvis has to grow and expand and separate some, as delivery is occurring. And so this hormone basically helps to make the collagen there, a little more flexible, et cetera. So that hormone plays a big role in the actual delivery. Of course, throughout this whole thing, we've got all the normal, gender-related hormones, oxytocin and progesterone and estrogen and things like that. I'm not going to get into that. That's a lot of endocrinology for what's a pretty straightforward lecture. So we divide a normal labor into 3 different stages. So that stage 1 is the onset of contractions to when the cervix is fully dilated. What happens during these initial contractions is that cervix has to begin to open up. Normally, it is very tightly closed, and it has to expand all the way out to, we consider it fully dilated at 10 centimeters, okay? Um, Once they are fully dilated, that's only part of the work. They also have to have the thinning of the cervix, called effacement. That thinning of the cervix is also incredibly important because that is the pathway that the baby is going to get out of that uterus and into the birth canal. Once we, have hit this stage of full dilation, stage 2 usually is relatively straightforward and is typically done within, an hour. That's when you go from a fully dilated cervix to now the baby is moving through the birth canal and you now have delivery of that baby. Once you are done with that delivery of the baby, you've now reached stage 3. You still have the placenta in there. And so now you have to wait for the delivery of the placenta in order to complete the process. So to do a field delivery, it's really most of the time straightforward. A lot of the field deliveries that we're going to do are not going to be in patients who this is their first pregnancy. These precipitated deliveries are usually a result of multiple, previous births. And so things are physiologically already kind of able to relax enough to progress quickly. It's unlikely that we're going to have to do a field delivery on a first baby, unless this person doesn't know that they're pregnant and thinks that they're just having abdominal cramping or something like that. Yes, that happens. Yes, I've delivered those in the emergency department, and it's not fun. The first thing is you want to make sure you've got a clean environment. Most of the time where you're going to be at is probably clean enough. If you think about it, 10,000 years ago, we were just delivering out in the middle of the forest. So try and get a clean delivery area. That old adage of, I need you to go boil a pot of water and find me some towels, etc. Really, that is more so that you can give people a task to do so they're out of your way. Yeah, clean towels are helpful. Boiling the pot of water takes a while, so they're out of your hair for, 15, 20 minutes. As baby begins to come out, we want to make sure that we're supporting that baby's head during the delivery. We want to make sure that we, after that face kind of has delivered, we begin doing some gentle suctioning of their nostrils and mouth with the bulb syringe. There's going to be a little bit of amniotic fluid. There may be a little bit of mucus that's in there. We want to get that cleared out, when we can. And then as the rest of the baby delivers, we want to make sure we keep a good, firm but gentle grasp on the child. I literally, ever since I was a medical student, every delivery I've ever done, running through my head the entire time is don't drop the kid, don't drop the kid, don't drop the kid, because they come out very slimy and very wet. And so don't drop the kid. It's poor form to drop the kid. So after the kid is delivered, you flip them out and up onto preferably mom's belly, okay? And clamp and cut the cord. You want to try and do that, probably a foot away from baby's umbilicus. And the reason for that is we don't want it to be too short. If it's too short, we have problems. We can always shorten it up more. So, feel free to use the length to your advantage. All right. After that, clamping is done. We really highly encourage, as mom is kind of cleaning up the baby, et cetera, stimulating the baby, that they try and do some nursing. That breast nursing really has profound physiologic effects for both mom and baby. It helps with the delivery of the placenta. It helps with, preventing postpartum hemorrhaging. It also helps get the kid, some needed nutrition right away. And the kid will begin to, perk up. It also allows for more prolonged skin to skin time. Hypothermia is a big problem in neonatal resuscitation. And so preventing hypothermia is kind of one of our biggest things. We're not doing a neonatal resuscitation lecture today, but getting skin to skin time between mom and baby is very important and prevents a lot of that hypothermia. So this is a still graphic of what the birthing process looks like. We're going to watch the animated version here in just a moment. But first, baby is going to come head first, typically. Most of the time, baby is going to deliver with their head, or I'm sorry, their face facing downward. Okay, that's normal. As the kid begins to come out, their shoulders then kind of have to clear the pubic bone. You can see there's that red star. That is an area where the kid can get tied up if that shoulder doesn't clear that pubic bone. We're going to go over here in a few minutes, all the process for freeing one of those. Then you deliver the posterior shoulder. And after that, my experience has been the kid comes pretty quickly after that. The shoulders are the widest area. The shoulders are the area where these kids are typically going to get hung up. Once you get those shoulders, the rest of the kid comes pretty quickly. And then you deliver the rest of the body and the umbilical cord, start stimulating that kid and getting them to nurse, cut and clamp, and take a breather. Hopefully the really hard part is now over. All right, we are going to watch this real quickly. Let me share computer sound. Get out of this and hyperlink open.
The first step of your baby's journey probably took place before your labor even began. Engagement is when your baby's head settles into your pelvis and is sometimes called dropping or lightening. The next step is called descent, and it happens while you're contracting and pushing. The baby's head may move a little to the left or right, and her chin up or down, as she shifts until her head is in the right position to continue her downward descent. Once she's in the correct position, flexion begins. Your contractions and the bones of your pelvis put a small amount of pressure on your baby's head. This pressure pushes her chin into her chest. Her head gradually rotates towards your pelvic bone as her head descends deeper into your pelvis. This allows the back of your baby's head, the widest part, to pass through the widest part of your pelvis. The next step in your baby's monumental journey is called extension. As your contractions exert downward pressure and your pelvic muscles exert upward pressure, your baby's head changes position. Her head, which was curled forward against her chest, is now extended backward, as if she's trying to look up at the sky. At this point, your baby's head emerges from your body. The next step, called external rotation, is when your baby turns her head to line it up with her shoulders. This is when you may possibly hear that first cry. The last amazing step in your delivery is called expulsion. The pressures caused by your contractions rotate your baby's shoulder under your pubic bone and upward. After the baby's shoulders come out, the rest of the body quickly follows, resulting in the birth of your beautiful baby.
So that's what a normal birth looks like. Give me just a second to. No, I don't want to do that. So that's what a normal childbirth, looks like in an animated way. Sometimes kids are born and their head has rotated the opposite direction, and so they come out face up. It's fine. The delivery itself goes pretty much the exact same way a normal delivery goes. It's just the kid is facing a different direction. So if you ever encounter that, that's okay. It doesn't necessarily mean things are going to be any more complicated than normal. After we've got this kid delivered, we need to do what's called an Apgar score. This Apgar score tells us how this kid is doing and responding to the environment around them. Okay, it's very important because it's a common scale that if you tell the other folks what the Apgar score is, it gives you a very nice, succinct way of saying, did this kid come out looking okay, or did this kid come out not doing well at all? The maximum score is 10. Don't try and remember this, okay? This is the kind of thing that you pull up on your phone, you open it up in ESO, whatever you're using. But the Apgar stands for appearance, pulse, grimace, activity, and respiration. A common mistake people make is that they try and score the kid immediately after the delivery. That's not how it's done. Every kid is going to come out looking a little blue and a little weird for that first minute, okay? That's normal. I'll tell you, when my daughter was delivered, even though I had delivered a ton of kids previously and been present for a ton of deliveries, that first minute was a scary moment. So because kids come out looking all kinds of, messy. So you score them at 1 minute, okay? At the 1 minute mark, you then go through, and we'll go through each of these steps. So activity, which is muscle tone. Active is 2 points. Absent, so they're floppy, is 0 points. Pulse, obviously, if they don't have a pulse, that's bad. That's a 0. If their pulse is over 100 beats per minute, that's 2 points. Okay. Grimace, which is also kind of like their irritability. If you irritate them, how quickly do they respond? If it's very prompt, that's 2 points. If they're again floppy, that's 0 points. Appearance. By this point, kids should have begun to pink up at the 1 minute mark. And so they will get a 2 if they're completely pink. They'll get a 1 if they have a pink body, but their extremities are still kind of, blue and mottled. And obviously it's a 0 if they have blue pale appearance. Respirations, if they've got a vigorous cry, which those cries are the best thing ever whenever you're delivering a kid, because you know that, okay, things are probably going to be okay now. A vigorous cry is 2 points. Slow and irregular breathing is 1 point, and absent respirations is 0 points. So you do that, all right, and then you have to do it again at 5 minutes post-delivery. It is normal for people or for the baby to increase their Apgar score. Almost no kids come out, a 10. Most kids are born, with an 8 or a 9, okay? So just keep that in mind when you're doing it. Most kids are not going to score a full 10. All right, so we need to get an obstetrics history on mom as well. And so this GPAL mnemonic is how you remember that. So it stands for gravida, term, preterm, abortions, and living. Now, abortions is not necessarily medical or surgical abortions. It's any kind of miscarriage. Okay, so that may be medical or surgical, or it can just be a natural miscarriage. All right, that is considered an abortion. So we present this as G21001. Again, probably don't need to remember this. The important ones are the G and the L. Okay. So a G21001 stands for a pregnant female with her second child. The first is living after a full-term delivery. Okay, that's what that means. It really is essential for understanding their obstetric risk because first pregnancies are much riskier than multiple pregnancies to a certain point. That first pregnancy, mom doesn't necessarily know what's going to be happening. Mom's physiology has not gone through this before, and so that first delivery, things can be a little tight and such. Multiple prior births, so we're talking babies 4, 5, 6 plus, those also can increase complications because the uterus at that point may have gotten thin enough that the muscles just simply can't contract as forcefully as needed, and so that can also increase their complication rate. All right, we need to do a focused OB physical exam. So we're going to ask them during this history taking about any contractions that they may be having. If they are, how long do they last? How much time is between them? Is there any bleeding or fluid leakage? Have they had, a bloody show, which is the mucus plug, coming out of the cervix early on in the delivery process? Are they still feeling the baby move? They should still be feeling the baby move. We want to make sure to check their vital signs and look for any signs of shock. So remember that pregnant female physiology is different. So their heart rate is going to be up. Their respiratory rate is going to be up just at normal baseline. It's unlikely that you're going to be able to check fetal heart tones without a Doppler ultrasound. Most ambulances are not carrying them, although the price has come down significantly. There is a technique, though, to being able to differentiate between, mom's pulse and baby's pulse when you're doing this. You sometimes, if you're in a really quiet environment, you might be able to hear baby's heart tones depending on where baby is in that uterus. But given that we're in the field, we are typically in noisier than normal environments, et cetera. I would be surprised if anyone was able to listen to fetal heart tones in the field. So there are some signs of imminent delivery. Imminent delivery is one of those things that's going to happen very quickly, which is why it's imminent. When somebody begins to go into that sign of imminent delivery, at that point, it's better to just stop and do the delivery, if you're able to. If you have not begun transport, guess what? You're probably too late. It's better to stay, deliver the kid, and then move, as opposed to, trying to deliver a kid that's, remember, slimy and slippery, in the back of a moving ambulance. So the mom is going to have this urge to push. They naturally are going to feel like they just need to bear down and push. You will begin to see crowning. Hopefully that is of the head, and you're not having a footling presentation. The contractions are usually less than 2 minutes apart between contractions. When you look, even if they don't have crowning, you may see the perineum beginning to bulge, and that's that baby's head, in the birth canal, moving its way down. You also may see that bloody show, which is that bloody mucus that gets delivered first. That typically, by the time we've been called, has already occurred, but sometimes that'll come, later on. All right, let's pivot a little bit and talk about some of the complications that can occur. Postpartum hemorrhage is unfortunately a leading killer of women in the peripartum time frame. We define postpartum hemorrhage as a blood loss of more than 500 milliliters after their delivery. Unfortunately, I've seen this numerous times in these precipitated deliveries. And so it's something that you really need to be prepared for. A lot of the time, it's because they have uterine atony, which is the uterus at that point is so exhausted that it can't contract down, after the baby has exited. Once the baby leaves, the uterus is supposed to clamp down and really work on pushing that placenta out. In addition, it needs to clamp down because those blood vessels that the placenta was using to feed off of, et cetera, they also need to spasm back down. So as that spasming occurs, it basically begins the clotting off process. However, if the uterus is too exhausted, it can't do that. The way we can help with this is by doing uterine massage. So literally you ball up your fist, and remember the uterus is going to be still fairly big. You're going to find that fundus or that top of the uterus. Typically it's going to be around the umbilical area of mom, and find that and literally start rocking your hand, with moderate force against that uterus, pushing slightly, not hard, but pushing slightly down towards the pelvis. The majority of what you're doing there is just rocking the uterus back and forth, and that stimulates it somewhat so that it can contract down on its own. Sometimes women will also have a retained placenta or part of a placenta. If that placenta is not fully detached or some of it remains attached, that area isn't able to contract down as well. And so those blood vessels likely have been torn, are bleeding, and can continue to be a problem. Unfortunately, this is something that requires an OB/GYN, to fix, because they sometimes have to literally go in there and remove that remaining placenta to get the bleeding to stop. Of course, trauma can also lead to this. It's rare that women will get a tear to the perineum that would cause this kind of blood loss, but unfortunately, it does sometimes occur. So we're trying uterine massage. We're trying IV fluids. At this point, we need to rapidly get to the hospital. There are additional medications, and like I said, OB sometimes needs to intervene to physically go in after something, but we need to begin rapid transport. The other thing that we need to do is TXA administration. The TXA is extremely useful in postpartum hemorrhage, and is something that as you're doing this uterine massage and getting fluids going, you really need to be hanging some TXA as well. All right, let's talk quickly about shoulder dystocia. So if you remember, with shoulder dystocia, that shoulder is getting hung up on that pubic bone, all right? And so what we need to do is help to get the kid moved appropriately so that that shoulder can deliver free. So the first thing that we're going to do is recognize that this is happening, and we'll see this so-called turtle sign, which is where the head is kind of moving in and out with the contractions, but is not progressing, okay? So the kid's head is literally coming out like that and not really progressing any at all. When that is occurring, we need to recognize that quickly and know that we need to intervene. It's a very simple intervention called the McRoberts maneuver. And what happens with that is you're going to lay mom back somewhat, and you're going to hyperflex their hips and bend their knees, just like that picture there of the nurse, okay? At the same time, you're going to begin applying, pressure over that pubic bone. We're trying to shove baby's body, downward in that birth canal. What we don't want is to do fundal pressure. We don't want to be pushing on the top of the uterus, because all that's going to do is get that shoulder even more stuck in that pubic bone. It's not going to help rotate that kid. So you do that. The good news is 90% of the time, that's all that's needed. 90% of the time, this simple, maneuver that takes 10 seconds to do, is all that's required to get this done. All right, we're going to watch again another video kind of on some of the shoulder dystocia maneuvers that can be done.
Shoulder dystocia and immediately announce it if resistance to delivering the shoulder is excessive or if, as seen here, the fetal head retracts after being delivered. Among the various maneuvers used to try and achieve vaginal delivery, McRoberts maneuver is often the first. Try to deliver the shoulder while assistants hyperflex and slightly abduct the hips. That's abduct. An assistant should also apply suprapubic pressure in the direction of the fetal head. Apply pressure to the suprapubic area. Do not apply pressure to the uterine fundus as shown here. Fundal pressure tends to increase impaction of the shoulder against the pubic bone and increases risk of fetal injury. If delivery is unsuccessful, assess whether the vaginal opening is wide enough to accommodate your hand for additional maneuvers. If not, consider episiotomy so that these maneuvers can be done. Shoulder dystocia and immediately announce it if resistance.
All right. So as you guys see there, it's a pretty straightforward procedure. They slowed it down, obviously, quite a bit.
To delivering the shoulder is
trying to get out of, there we go. They slowed it down quite a bit, just so that way they could educate on it. Obviously, we are not trained in how to do episiotomies, in the field. So if the McRoberts maneuver does not work, there are some other maneuvers that you can do to help free things up. But that's the McRoberts maneuver. It's going to work, 90% of the time. Prolapsed cord is something that we will sometimes see. The cord being wrapped around baby's neck is actually a fairly common thing. And as long as you're able to get that cord kind of unwrapped around the neck, it's no big deal. A prolapsed cord, though, is when the cord is coming out before baby has. And that is a very big problem. As the baby has to deliver, there's going to be a lot of pressure being put in that birth canal, and that's going to clamp off, any umbilical cord that's in there, and that's going to cut off baby's blood supply. And remember, if the head hasn't delivered yet, baby isn't able to, oxygenate themselves yet. So this causes a real big problem. What we want to do there is elevate whatever presenting part manually to reduce compression. We want to try and have mom stop pushing because likely what's happening is that cord is being compressed by baby's head with every contraction. And so we want to, get this pressure relieved off of that umbilical cord as much as we can. And that is going to require you probably putting your hands within the birth canal. We also want to do knee to chest. So similar to that McRoberts maneuver, knee to chest or the Trendelenburg position, and run like hell. You're going to want to get that person to the emergency department as quickly as you can, calling well ahead, because that kid is either going to be delivered very quickly or is going to be in emergency C-section very quickly because we need to get it dealt with. Sometimes these kids deliver, prior to getting to the hospital, and that's okay. If this has been a prolonged prolapsed cord, though, be prepared. You may have some neonatal resuscitation that you've got to do. Breech delivery is another thing. It's less common here in the United States because we have, maternal fetal care ahead of time. And so because we ultrasound, women throughout the pregnancy, we typically will know if a kid is breech. There are some things that they can do to, try and get the kid repositioned, et cetera. If that doesn't work, then, depending on the OB and the patient, they may elect to do a cesarean section just to make things, a little safer. There are three different kinds of breech delivery. There's the frank breech, which is where the butt is what's coming first, and the feet are basically up by the kid's ears. There's complete breech, which is where, the feet are coming, at the same time. They're kind of crisscrossed, and the knees are flexed and the hips are flexed up against the rest of the body. And then the footling breech, which is where only one foot is coming out initially, and that has a higher complication rate. Don't pull the infant, okay? That's the number one thing, is don't pull the infant. The head delivery is, going to be last. And remember, that head is supposed to have moved in certain directions as it progresses through that birth canal. Well, it's not going to have done that. And so if that head gets hung up on that pubic bone, we've got problems. And so pulling on that infant is only going to make things significantly worse, and it risks injuring that kid's neck as well. So with that, we do the Morrisell-Velt maneuver. Luckily, I was able to find a better video than the protocol training video that we did, just a couple of months ago on this. So, or I'm sorry, a better graphic. So what you do with this is, again, you're going to have some suprapubic pressure being applied by the assistant, okay? You're going to have your hands in the birth canal supporting baby's head, and you're going to have your other hand supporting baby's face. You want to then flex that kid's, chin down towards their chest, all right? And then as that face begins to deliver, you kind of rotate them up towards mom. So it's almost like they're tumbling backwards out of mom's canal. So they deliver in that situation face first. What you don't want to do is you don't put your fingers in baby's mouth. You don't want to be, forcefully flexing or extending things. This typically only requires a little bit of pressure. I will be perfectly honest. I've never actually done this because I've never had a breech delivery. But you may run across it if somebody doesn't know that they're pregnant and is now getting ready to deliver. And so we never had the opportunity to, recognize that breech delivery. All right, take a breather. We're done with the main parts of the delivery process, okay? So now we're into more of the, obstetrical type emergencies that can occur. Preeclampsia and eclampsia are a major problem. The United States is not doing well in industrialized nations when it comes to recognition and treatment of this. Preeclampsia is when the toxemia of pregnancy is kind of in its initial stages. So the patient will become hypertensive, their kidneys will begin to spill protein into their urine, and because they begin to lose some of this protein, the fluids are not able to stay within their plasma and so leak out into the interstitial space. So they begin to develop edema. The patients that are at highest risk for this are the significantly young, female, or the advanced maternal age. I'll leave it at that. Not my definition, okay? So don't hate on me. That's 35 and up. So patients that are 35 years or older are considered advanced maternal age and are at a slightly higher risk of developing preeclampsia. If we recognize it initially, which we should, we can then begin treating it, all right? We know that this kid is going to be likely an induction, and what we look for are, worsening signs of this preeclampsia. We want to try and get that kid incubated as long as we realistically can. But sometimes this requires us to do a C-section or, initiate a delivery with medications prior to their due date. If this isn't recognized, or if it's a more significant case that the treatment is just not succeeding, they may develop eclampsia. At that point, we've now reached, an emergency, all right? This is where mom is going to begin to have seizures during the pregnancy. and baby is at high risk. At this point, we're now to the C-section range. This kid needs to get delivered very quickly. We typically need to do a lot of blood pressure management for mom as well, and they have a higher risk of postpartum hemorrhage. The management of this for us in the field is going to be airway, oxygen, IV access, mag sulfate, and we also, if the person is still actively seizing, we're going to use our midazolam or Versed to treat the active seizure. So if they're actively seizing, the initial treatment is just like a normal seizure, okay? It's just we add some magnesium at the end. If they're no longer seizing, we don't necessarily need to do the benzo. We can then just give the magnesium, all right? The magnesium that we give is 4 to 6 grams. So it's actually typically a couple of vials diluted in 100 milliliters of normal saline, administered IV over 20 minutes. Do not push mag sulfate, okay? If you push mag sulfate, that person is going to stop breathing, okay? Mag sulfate is a smooth muscle relaxer, and so that's going to make things significantly worse. It's probably also going to drop their blood pressure. Alternatively, you can do mag sulfate 10 grams intramuscular in a deep Z track in the buttock. Typically, this is going to be 1 5-gram injection into one side and another 5-gram into the other side. And with the Z track, what we mean is you're going to lift and tighten the skin prior to putting the needle in. That way, when you let go, things are not a straight line anymore. Okay, and so that fluid is less likely to leak out. I will tell you, these hurt like hell. Okay, so I always warn the patient if we have to do this, that this is going to hurt like hell. Really sorry, and it's going to hurt like hell for a few days. All right, they're both about equally efficacious, so it doesn't really matter which one you do. Hypertensive crisis. So we, instituted a hypertensive crisis protocol in the greater Cincinnati area. I think it was now 2 years ago. And we've had pretty good success with this. Again, just to reiterate, the reason we're doing this is because hypertensive crisis in pregnancy, again, is one of those concerns, of preeclampsia. And we don't have the greatest outcomes in the world on this. And Ohio, in particular, did not have very good outcomes when it comes to this. This does lead to increased mortality and complications. These women are at a higher risk of developing hypertensive cardiomyopathy as a result of this. So it really does pose long-term consequences. And so we're on the front end of this. We're not the first, but we're also not past the curve by treating this. So the criteria for this is you've got to have a sustained systolic blood pressure of greater than or equal to 160 and or a diastolic blood pressure of greater than or equal to 110 on 2 occasions at least 15 minutes apart, okay? Now, those of you that are close to a hospital, you may recognize this, but may not have the chance to treat it, okay? If you recognize it and you're basically at the hospital's door, you want to make sure that you notify the hospital that you believe this patient is having a hypertensive crisis. And I would document that you thought this patient was having a hypertensive crisis, but couldn't administer the meds because you were basically at the hospital, okay? Those of you that have longer transport times, you're probably going to come across this at some point in your career. The treatment is really easy though, all right? We administer oral nifedipine, 10 milligrams, every 15 minutes to a maximum of 3 doses if that blood pressure remains within that criteria, okay? You want to try and attempt IV access, but it is perfectly safe to administer this nifedipine orally without IV access. So it's okay to give them the nifedipine and then work on the IV access, all right? Again, notify the hospital of your concerns over hypertensive crisis because it's one thing for us to recognize and begin treating it. It's another thing for the hospital to continue that treatment. And we're not doing a very good job in the emergency departments or in labor and delivery of recognizing this and appropriately treating it. All right, so third trimester bleeding. This is always something that is scary for everyone involved. A lot of the time, it's going to be nothing. Sometimes it may be this condition called placenta previa, which is where the placenta has implanted and is now covering the cervix. That kid has to be delivered via C-section because obviously you're not going to tear through the placenta to deliver. However, because that placenta is right on that cervix, it's not attached at that cervix as well. And so you may get a small amount of bleeding from that. That is painless bleeding, okay? Painless bleeding is far less concerning than painful bleeding, okay? Placental abruption is painful bleeding. The uterus is now firm, okay? It's going to be like a rock. And the bleeding can sometimes be brisk. With placental abruption, that placenta has torn away from a part of the uterus. And as a result, you're now going to get blood leaking down around that amniotic sac and down into the vaginal canal. This is a surgical emergency. These kids are going to almost invariably be delivered via C-section emergently. Mom can go into shock from this. And so when you have painful uterine bleeding, especially in your third trimester, you need to treat them for shock, rapidly get them to an OB-capable facility with early notification, because they may even have you go straight to the operating room with something like this. Premature labor. So again, premature labor is any labor before that 36 to 37 week gestation range. Whenever you're going to do this, you need to consider your neonatal resuscitation needs. And, that may be that if you think you're going to have to deliver this kid on scene and this is going to be a preterm infant, you may be best requesting a second ambulance, not just, additional personnel, but additional equipment. Because it may be that you're going to have to resuscitate both mom and baby. And so having a second ambulance that's capable of doing a complete resuscitation independently is important. If it is safe for you to transport, immediately, then do that. These preterm infants, though, because they are much smaller, their deliveries are very, very, very rapid. The youngest I have ever delivered was 24 weeks. And that delivery was over and done with before I completely had my shoe covers on. They also, though, can have a risk of lots of complications for mom, in addition to, obviously the concerns about baby and a neonatal resuscitation. So make sure and, recognize this and begin transport if it's safe to do so. The protocol does spell out, the criteria of where you should go. The two highest level neonatal ICUs that we have in the area are at Good Sam and at UC. Okay, so those are the two places that should be able to handle almost anything that you can take to them. All right, let's talk very quickly about trauma. So trauma is actually pretty straightforward in pregnancy. Because we just essentially forget about the fact that they're pregnant, all right? We want to make sure that we prioritize maternal survival. One of the things that OB drives into your head when you're a med student is if you're treating mom right, that's probably treating baby right, okay? So don't freak out that this is a pregnant person that has trauma. This is a trauma patient. Treat them like a trauma patient. They just happen to be pregnant, all right? However, the one thing that we do want to do is put them in that left lateral recumbent position so that we're maximizing that venous blood flow back to the heart. So have them tilted over, onto their left side. All right. Anybody who is involved in, any sort of, moderate to severe trauma, who is 23 weeks or over, really needs to go to the hospital, and they need to go to a hospital that's capable of doing labor and delivery evaluation. All right. A lot of the time, these patients will be put on monitoring, et cetera, and sat there for hours. It's called a non-stress test. And it basically is there to make sure that we're not missing something that, might be present as a result of this trauma. So this could be a fall down a couple of steps. This could be an assault. This could be an auto accident where, the seatbelt was on, mom's concerned, et cetera. Get them to a hospital that has labor and delivery. That way they can do that, that non-stress test monitoring of the baby. All right. It's also important that we monitor for concealed bleeding. If the mom sustained any sort of abdominal trauma, of course, there's risk of damage to baby and placenta. So we want to make sure that, mom is checking to make sure she's not having any bleeding through the perineum. Cardiac arrest. So all of you guys should hopefully know by now, cardiac arrest is one of my big, passions, et cetera. This is one of the only times you're ever going to hear me, say, basically pick up and run. Okay. If you've got a pregnant female that's in cardiac arrest, yes, we want to prioritize maternal survival, but we also have a very narrow window of time to save baby. Cardiac arrest in pregnancy is rare, but the physiology is different. And we've got decent evidence, it's not great evidence, but decent evidence that if we do a perimortem C-section on these women, the women increase their risk of, or increase their rate of survival, and the baby increases their rate of survival. So this is one where you want to, of course, still minimize interruptions, but this is we're going to get this person very quickly moved to the ambulance and to any emergency department that can do a possible emergency C-section. Every board-certified emergency physician in the country has to know how to do one of these types of C-sections. They're not pretty, they're quick, and they're very efficient, and get baby out. And then we can move on with continuing the resuscitation. This gives mom and baby a higher chance of survival. Okay, so again, this is one of the few times you're ever going to hear me say in a cardiac arrest to scoop and run. This is one of those ones where CPR is important, but we need to get moving as well. If the Lucas device will fit on the patient and is not pushing on the uterus, we can use it. So it's totally fine for us to use the Lucas device on a pregnant female as long as it fits and it's not pushing on the uterus. Pregnant females' airways can be difficult. Again, they have some soft tissue swelling just at normal baseline. Also, their physiology has changed because they've now got this big uterus and baby shoving up on their diaphragm and up on their lungs. And so as a result, their reserves are significantly reduced. Be very careful when you're handling these airways. If they are easy to bag and that's adequate, then that's what I would stick with. Intubating a pregnant female patient, can be fraught with problems. And so if they're able to be bagged, just bag them. If you need to use an adjunct airway, such as, an iGel or a King tube or an Air Q3, whatever, that's okay as well. But just keep in mind that, airways can be difficult in pregnant females. All right, so let's talk real quickly about, case number one. So let's talk about a prolapsed cord in a rural setting. All right. So we're out in, Brown County. We've got a female who, this is her third kid. She's been having some contractions for a little bit. She talked to OB. OB said, when your contractions, get to 5 to 10 minutes apart, et cetera, it's probably time for you to come in. All right. So, she's about ready to go into the hospital when she, goes to use the restroom and feels the umbilical cord sticking out of the birth canal. We get called, to go out there and assess things. I'm going to be generous. We've got ALS on board. Okay. So I'm not going to make this an EMT basic scenario, but we get there. Our initial priorities are going to be getting mom, out and moved to the cot after we've assessed things. We want to try and elevate any pressure we can off of that prolapsed cord. All right. And we want to begin rapid transport if this kid is not going to deliver, en route. Now, Brown County, it's tough. All right. Mercy Mount Orab can do a delivery, but they can't do a C-section unless the mom is essentially dead. Mercy Claremont can also do a delivery, but can't do a C-section, unless mom is basically dead. This is going to be a long transport. This is going to be a transport where we get them to Mercy Anderson, or we get them to another OB capable facility that can actually do a C-section. This is not something where a pit stop is going to be beneficial. In fact, it's likely to be harmful. Oh, and by the way, the aircraft is not going to fly someone in active labor. I'm sorry. Yep, they giving birth in the air is not a good thing, especially in a small helicopter. So the unfortunate thing is you're in for a ride. Okay. If you can get extra hands because somebody is basically going to be there supporting the umbilical cord, keeping an eye on the birth canal, et cetera, while somebody else is, taking care of mom, vital signs, making phone calls, that kind of thing. Again, very early on in this transport, you're going to want to notify wherever you're going so that they are ready and prepared. This is hopefully going to be a situation where labor and delivery is meeting you at the back door, and taking over care fairly quickly. All right, case number 2, third trimester MVC. All right, so we've got a female who's 37 weeks along, pregnant. This is her second kid. She's involved in a moderate MVC. The car is not drivable, but nobody is really injured. Okay. The initial assessment that we're going to do is just like any other patient. We're going to get a set of vital signs. We're going to do a head to toe, make sure that we're not missing anything. We are going to want to pay special attention to the abdominal exam, because again, we want to feel what that uterus feels like. We want to make sure that we don't see any seatbelt sign, that we don't have, mom reporting any bleeding from the perineum, et cetera. Even if everything is checking out okay, this is still somebody that we should really highly recommend going to the emergency department. And it really needs to be a hospital that has OB capabilities. As silly as it sounds, unless you have labor and delivery at your hospital, you're very unlikely to have any of the appropriate monitoring equipment to watch this mom and fetus in the emergency department. And so they're just going to end up getting transferred to a facility that does, and all it does is delay care. So strongly encourage this mom to go with you to the hospital, and if not going with you to the hospital, that they're calling their OB, to discuss this, because their OB is going to read them the Riot Act and say, no, you need to come in so that we can evaluate things. Okay. All right, case number 3. Postpartum hemorrhage after a home birth. So this is, a family that wanted to deliver the kid at home. They have a doula. In the state of Ohio, I think there's a little bit of training that a doula has to go through, but a doula is not a midwife. Okay. So they have somebody there that's basically there to help coach them through the delivery. All right. So deliver the kid, and mom begins to bleed vigorously following delivery of the kid. A few minutes go by, they're not able to get the bleeding stopped, and so they call 911. We arrive, mom is pale and diaphoretic, and still actively bleeding. All right. The first things that we're going to want to do are, 1, make sure that umbilical cord has been clamped and cut, because we need to get baby out of the picture and ensure they're being taken care of. This is one where while somebody is trying to establish IV access, we are beginning to do that fundal massage. All right. So again, balling up that fist at around the mom's umbilical cord area, and rocking it back and forth, slightly pressing down towards the pelvis to begin to get that uterus to hopefully contract. Once we've got that IV access, we're going to begin giving IV fluids. If we're at a point where we can now begin transitioning to the cot, great, let's get to the cot. And then let's get some TXA on board. This is, again, another situation where we're going to want to have early call ahead to the emergency department. This is, again, one of those situations where labor and delivery may meet you at the back door so that they can get the patient upstairs. They may even start them on some of the medications that we can use to treat this while they're rolling upstairs. This is not a patient that should go to any emergency department. This is a patient that really needs to go to labor and delivery if it is safe to do so, because, again, this sometimes requires physical intervention, and emergency medicine, we're not trained in how to remove a retained placenta, et cetera. I always would, whenever a pregnant female was coming in saying that she was thinking she was going to deliver, my line that I would always go is, I don't know nothing about birth and no babies. If I never delivered another kid in my life, I would die a very happy man. And I think most of the emergency physicians I know would agree with that. So let's get them to labor and delivery where an OBGYN can take care of. All right, so some of the key takeaways for us is, we've got to recognize pregnancy and its related complications, and we've got to have swift intervention with some of these. We've got to be very good at doing both maternal and fetal assessments. And it's really important that you guys kind of watch some of these YouTube videos, at least do some mental exercises of how I would, go about delivering somebody if you don't have access to an OB simulator. If you have access to an OB simulator, go for it. It's going to be much better than any mental exercises you can do. And be confident. Remember that women have been delivering babies without medical support for tens of thousands of years. The difference is that they had higher death rates then. But most deliveries are going to go off without any sort of a hitch. And it's just going to be a great experience for everybody to talk about at the station after you've cleaned up everything, because it's going to be messy. All right. Your OB kit should have, at the very least, sterile gloves, should have some sterile towels, a bulb syringe, cord clamps, which are literally, they're going to look very similar to the plastic chip bag kind of clamps, scissors. It's probably also going to have a scalpel, OB pads, so some pads to lay down like chucks. You're also going to need, some sort of suction if you need to do a resuscitation, oxygen. There should be a baby blanket. Some of them will even include one of those little baby hats. I'm not sure what everybody's, carry, but at the very least, we've got blankets and towels on the ambulance, skin to skin with a blanket or towel over mom and baby to keep them warm. All right. Questions? I'm assuming there won't be any, but. All right. Well, not hearing any and not seeing any in the chat. That is it. Make sure and fill out your evaluations and your attendance sheet, et cetera, so you can turn it in to your station to get whatever credits are coming your way. Thanks for coming. If you have any feedback, let me know. Otherwise, we'll see you on the next one.